Hello, good evening, everybody. Mr. Dr. Jan,
Yes, sir, please.
should we start?
Yes,
So, good evening, everybody. We are in for another session of GAPU today. We have today the gastroenterology sessions, and we have three young gastroenterologists from Apollo Gastroenterology Sciences Department, Calcutta. And each talk would last for about 15 minutes, followed by a couple of questions, which we'll take from the chat box or between the speakers. And the first talk is by Dr. Avnish Tiwari. Dr. Avnish Tiwari is a DM from Chennai and has joined as a consultant in Apollo Multispecialty Hospital for more than 2 years now. His main interest is in small intestinal diseases and is an expert in enteroscopy, particularly the latest module of enteroscopy, which is novel spiral enteroscopy. So we would be hearing Avnish for the first presentation.
Thank you, sir. Thank you for giving me this opportunity. So I'll start with my presentation. This is on obscure GI bleed. As we all know by definition, obscure GI bleed is characterized by continuous or recurrent GI bleed originating in the GI tract after both upper and lower endoscopies yield no evidence of source. It has been further classified into overt and occult. In overt, we have clinical signs of active bleeding in form of hematochezia, hematemesis, or melena, whereas in occult, it is usually either a fecal occult blood positive or iron deficiency anemia. This obscure GI bleed makes up for about 5 to 10% of the all reported cases of GI bleed. If we see at the common causes for the obscure GI bleed, we can classify into 4 parts like ulcerations and erosions, vascular, tumor and polyps, and others. Ulcers, we can have peptic ulcers, NACID induced ulcers, Cameron ulcers, or one related with Crohn's and tuberculosis. Then in vasculars, we have deulofoil lesion, autoenteric fistulas, GAVE, ectopic varices. Whereas in tumors, it can range from benign to malignant in form of polyps, lipoma, carcinoids, lymphoma, adenoseo, or GIST. Others we can see as Meckel's diverticulum or amyloidosis. So when we have a patient with obscure GI bleed, we initially stabilize the patient, do the routine investigations in form of CBC, LFTs, and RFTs. Beyond that, when we do upper GI endoscopy and colonoscopy to look for the cause. Once we don't find any evidence on upper GI and lower GI endoscopies, then we go in 2 ways. Either we do or maybe a combination of 2 by doing an endoscopy or a radiology. We'll be only discussing on the endoscopy part. So when we do endoscopies, the options which we have is capsule endoscopy, single or double balloon enteroscopy, spiral enteroscopy, or intraoperative enteroscopy. Whereas in radiology, we can do CT or MR enterography, angiography, conventional or CT, or nuclear scans. Before we go into any of this further evaluation, the first thing which we usually do is do a second look endoscopy, because studies have shown that we usually miss lesions on which we can deal on conventional endoscopies, and the diagnostic yield ranges from 2 to 25% in case of repeat upper GI endoscopy to 6 to 23% in case of repeat colonoscopy. The potential causes usually being too much of blood obscuring the examination. Second is an intermittent nature of the bleed, and obviously the endoscopist expertise. Now, capsule endoscopy. So capsule endoscopy, it has the capacity to take images at a rate of 2 to 6 frames per second over a period of 8 to 12 hours. The advantage is that it is a non-invasive evaluation. It does a non-invasive evaluation of the entire small bowel in about 80 to 90% of the patient with a diagnostic yield from 40 to 80%. It has a high positive and negative predictive value when we are doing evaluation for GI bleed. If we see the reported diagnostic yields, it's about 35 to 90% when we are doing it for an obscure overt GI bleed, about 40 to 60% when you are doing for an occult bleed, and 40 to 60% for an unexplained iron deficiency anemia. The most common causes being in these studies, in these studies being angiodysplasia in about 50% of cases, ulcers in about 25 to 30% of cases. The diagnostic, I'm coming about the timing, the best time would be to do it within 48 to 72 hours, but the yield is good if we are doing it within the 2 weeks of the bleeding episode. If we see the incremental yield of capsule endoscopy in upper GI bleed, it is as good as intraoperative endoscopy. And if we compare it with other investigations like CT, it is about 50, CT or MR, it is about 50 to 60% more, and with angio, it is about 30% more. The limitations of capsule endoscopy being inability to provide direct therapy, inability to localize the exact lesion, exact point where the lesion is, erratic passage of the capsule through the small bowel, retention, and patients with dysphagia or altered anatomy. Dealing with the last problem, we have capsule delivery devices. We can place the device with the help of these devices, we can place it directly into the duodenum. About the second problem, which is retention, we have dealt with such problem by using spiral or in past single balloon endoscope to retrieve the capsules from the obstructed lesion, as we can see in this video. That we are using this rock basket to retrieve the retained capsule. So these are few of the lesions which we have seen during our period with capsule endoscopy, like ulcers, worms, strictures, polyps, dysplasias, and varices. So this paper was published by Goenka sir in about in 2011, where the total number of capsules done for obscure GI bleed was 435, of which the positive yield was about 73 to 73%. The most common lesion being ulcers and tumors. The lesions which were missed was Meckel, AVM in 3 cases, and ulcers. The capsule retention was there in about 10 cases out of the 435 cases done. In another paper done by Sir, the total number of capsules done for obscure GI bleed was 677 out of the 942 cases done. And the positive yield was another 60%, in which ulcers were about seen in 20 to 80 cases, and tumors were found in about 84 cases, AVM in 34. Missed lesion being the same, Meckels, AVM, and ulcers. The capsule retention was there in about 13 cases. There have been a lot of studies which has been published on capsule endoscopy from our Indian gastroenterologists, like in 2006 by Dr. Gupta from Hyderabad, in which 154 cases were reported, the diagnostic yield being 52%, and the angiodysplasia being the most common lesion. Similarly, in 2011 by Ghusal sir from Lucknow, it was about 86 cases, and the yield was about 75%. Goenka sir one, which I have already told you, but in 2016, Dr. Pandey had published this from Mumbai of about 68 cases, showing an yield of 65%, with NSAID-induced ulcers being the most common lesion in the study. Coming to the balloon-assisted endoscopy, these balloon-assisted endoscopes allows for the visualization of the small bowel through the use of an overtube and balloon to grip the small intestine and advance the scope. It is about 200 centimeters long and has a capacity to do a deep endoscopy up to proximal ileum. The factors which are predictive of a positive outcome is if you are doing it in a case of active overt as compared to inactive overt. If you are doing in a case of overt over occult, if the interval between the endoscopy and the presentation is short, or if the patient has severe anemia, having multiple bleeding episodes, and more importantly, if you are doing it from an antegrade approach as compared to the retrograde approach. So this is about a patient who had presented with anemia with a fecal occult blood positive, was found to have polyp. Double balloon endoscopy was done to reach the site, and polypectomy was done and following which the polyp was retrieved for further histopathological examination and further management. This is about a patient who had presented with a GI bleed. He was having hemoglobin in ranges of 6 to 7 when patient was hemodynamically stabilized. Then capsule endoscopy was done, which showed bleed from distal jejunum. And when when capsule and this single balloon endoscopy was done, we found to have dielophile lesion for which APC was done and hemostasis was achieved. The limitations of this balloon-assisted endoscopy is it is time-consuming. The average time ranges from 75 minutes to 120 minutes. It has lower pan-endoscopy rates, though in Japan it has been reported to have 70 to 86%, but while in other studies it is 4 to 45%, and it requires more than two endoscopists or more than 2 persons to perform this procedure. If we compare capsule versus balloon, there have been in a meta-analysis of 11 studies, it was found that the diagnostic yield was 60% for capsule, whereas 57% for balloon assisted. But if we see deep into the paper, we will see that yield for double balloon endoscopy was higher when it was performed after a capsule endoscopy, which was about 75%, whereas it was done before doing a capsule endoscopy, it was lesser, about 27.5%. So this approach of targeted double balloon endoscopy has been reported to increase the diagnostic yield and the therapeutic yield. Now coming to this motorized spiral endoscopy, this endoscopy, when introduced after being introduced in 2015, has changed the approach by which we evaluate the small bowel. It has a spiral motor which helps the scope to progress forward, thereby pleating the bowel on the scope. It requires only 1 person to do. It has a more depth of insertion. It has better control in while performing therapeutic procedures. The biggest advantage of doing a spiral endoscopy is we can have pan endoscopy rates which are much higher as compared to other modalities. Like in this picture, we have done an pan endoscopy in a patient where we have started from the endoscopy from oral end, and we could reach the cecum. We have done about 60 cases till now, of which we could do endoscopy in 58 cases, on which we had done antegrade in 22 cases, whereas retrograde in 33 cases, and we had to use both approaches in 3 cases. 1/3 of the cases were for GI bleed. So if we look into this case, who had presented with GI bleed, was found to have deep jejunal bleed, for which spiral endoscopy was done. We found that the patient had dielophile kind of lesion. We applied hemoclips on this patient, and we could achieve hemostasis. The patient could be discharged on very next day after this procedure. Then this was a patient who had presented with a stool for occult blood positive, was having abdominal pain. We had done CT angiography. We found that the patient was having proximal ileal thickening. We did a spiral endoscopy by retrograde route. We found this patient person was having multiple deep ulcers. After taking biopsies, we performed APC for this patient. We could stabilize his hemoglobin, and we could get a diagnosis of Crohn's disease, for which he was is still under treatment with us. Then this is about a girl who was 19-year-old who had come with anemia, abdominal pain, and subacute intestinal obstruction, for which CT angiography was done. This patient, when we did the CT angiography, we found jejunal narrowing. We went with the spiral endoscope. We did CRE dilatation for the patient. We took biopsies. The surgery for this patient could be avoided. We started after histopathological examination, we could start her on treatment for Crohn's disease, and she is stable and doing well presently. So how do we approach any patient who comes with a suspected small bowel bleed? First, we look whether it is an occult or an overt bleed. Then we decide whether we do a repeat endoscopy. If it is positive, then we treat accordingly. If it is negative, then we proceed with small bowel evaluation. If a patient with small bowel evaluation has features suggestive of obstruction, then we go ahead with CT or MR angiography. If not, we go ahead with capsule endoscopy. Depending on the results, we go for specific management in form of push endoscopy or deep endoscopy using single balloon or spiral endoscopy, or rarely intraoperative enteroscopy. And if we don't find anything, we follow up the patient. Thank you.
Thank you, Avnish. We had initially planned that we'll have a discussion together at the end, but if Dr. Jain agrees, then we can have a couple of questions taken up because the topics are not directly related to one another. So Dr.
Right.
Jain, is that fine?
Yeah, please, sir.
So, Avnish, good presentation, very comprehensive. The main question which I have to ask you is that we have so many modalities now. We
Yes.
have enterography, MR and CT enterography. We have capsule endoscopy. We have balloon enteroscopy, and we have spiral enteroscopy. So, can you, in a given patient, how will you proceed? You did show us the algorithm towards the end.
Yes,
But
sir.
will you want to do call it capsule endoscopy in all patients before you do enteroscopy, or there are some patients where you'll directly go for device-assisted enteroscopy?
So patients who are with high risk, like having a severe cardiac illness, in that cases, I'd like to have capsule endoscopy before doing a spiral enteroscopy because it is an invasive procedure. Capsule will help me even in directing which direction to take, so whether to go from antegrade route or a retrograde route. Otherwise, sir, I'll be comfortable doing a spiral enteroscopy in any patient who presents with GI bleed.
So if a patient presents with GI bleed and you're planning either a device-assisted, any of the device-assisted enteroscopy, whether it's balloon or spiral, do you prefer to go antegrade first or do you prefer to go retrograde first?
Sir, in the studies, in the number of cases that we have done, sir, I have found that if we go by antegrade route, sir, the depth of insertion is more as compared to the retrograde route. So my choice would be always to go from antegrade route. Unless an imaging imaging has been done, which suggests me the other way.
Anybody else has any questions? Nikhil, you want to ask any question or anybody?
What
I can see other gastroenterologists.
Absolute contraindication to do spiral vis-a-vis single balloon?
Sir, this actually, when we started doing spiral enteroscopy, we had many contraindications, but now we have limited to patients who have, suppose, large esophageal varix, then we cannot take the antegrade route. If they have any strictures or if they have any mass, then we cannot take the antegrade route. And if the ASA is more than 3, if the patient is not stable for general anesthesia, then we can try to avoid spiral enteroscopy. Otherwise, we can do enteroscopy in almost every cases. The horizon is expanding for this procedure. Earlier, many things were contraindication. Now, earlier, even diverticulosis was considered contraindication. Altered surgical anatomy was considered contraindication. But now, in all of these patients, spiral is being done, and it is found to be safe.
Thank you.
So if there are no more questions, we will move on to the second presentation for today. The second presentation by another young gastroenterologist, Dr. Nikhil Sonthalia. Dr. Nikhil Sonthalia is also a consulting gastroenterologist at Apollo Multispecialty Hospital, Kolkata, and is working at Apollo Hospital at our setup for more than 2 years now. Dr. Nikhil has done his fellowship. Also, he's done his DM from Mumbai and has worked as a fellow in Prince of Wales Hospital, Hong Kong. He's also received a number of awards, including Berenson's Advanced Scholarship from Harvard Medical School, and recently he received Emerging Star Award from World Endoscopy Organization, as well as is a component of a special group formed by Asia Pacific Association of Gastroenterology for emerging leaders from Asia Pacific region. He's published more than 40 papers. He's an aggressive intervention endoscopist. Nikhil will be talking to us about role of endoscopic ultrasound in general practice. He will give you an overview about this now a well-established technology. Any advanced endoscopy center today would be incomplete without an EUS setup.
Thank you. Thank you, sir. Thank you, sir, for kind introduction. So I'll take you through to a variety of applications of endoscopic ultrasound that is emerging in our day-to-day practice. So to just simplify, EUS is nothing but convergence of ultrasonography with endoscopy, where an ultrasound probe is attached to the tip of the endoscope, which allows us detailed evaluation of the GI tract and its adjacent structure. It has been in use for more than 3 decades now. So broadly, there are two varieties, linear and radial, but there are other varieties like forward and mini probes. In our clinical practice, we 90% times use linear EUS scope, which gives us an option to acquire tissues and do interventions. And the second variety is, of course, radial, which gives us a 360-degree view, but without any interventions. So basically, EUS allows us to see esophageal wall, mediastinal structures, gastric wall, perigastric structures like pancreas, celiac vessels, liver, gallbladder, spleen, left adrenals, left kidneys, duodenum, duodenal wall, ampulla, pancreatic head, common bile duct, gallbladder, portal vein, and white kidney, and rectum, rectal wall, anal sphincter, perirectal structures, and iliac vessels. So the broad diagnostic use is evaluation of GI luminal tract diseases like GI cancers, including esophageal, gastric, and rectal cancers, GI wall submucosal lesions, and evaluation of pancreatic biliary diseases, known or suspected case of pancreatic masses, pancreatic cysts, biliary stones, and acute and chronic pancreatitis. These are the traditional uses. Then there are a lot of additional uses that has been emerging, which I'll talk about. So therapeutic use includes US-guided pseudocyst walled-off necrosis drainage, US-guided celiac plexus interventions, US-guided biliary drainage, US-guided gastric stenostomies, US-guided variceal coiling, and glue injections. And apart from this, now in the era of endohepatology, it has become a important tool for evaluation of chronic liver disease, as well as in oncology setup, uses as US-guided radiofrequency ablations, and various access routes are being described. So the basics is, when we evaluate EUS, we see anechoic, hypoechoic, or hyperechoic structures. So GI tract is basically divided into a 5-layer structure based on the EUS image, where first layer is an hyperechoic mucosal layer. The second image is an hypoechoic muscularis mucosae. The third layer is again an hyperechoic submucosae. And the fourth layer is hypoechoic muscularis propria. And the fifth layer is serosa. A knowledge of this is very important to identify the layer of origin of any mass or any abnormality, and to then plan treatment according to the layer of origin. So in brief, I will talk about the different clinical scenarios. In esophageal cancer, the main use is determining a local extent or the T staging and the end staging of the tumor. It is a complementary role to other cross-sectional imaging, including CT scan and PET scan. It guides treatment based on the tumor stage. In very early esophageal carcinoma, if you see a T1 lesion, which is conforming to superficial submucosae or just mucosae, then you can opt for some endoscopic therapy or a direct surgical therapy instead of going for neoadjuvant therapy. So early esophageal cancer surgical decisions can be altered by EUS. It's very common to find lumps and bumps in GI tract when we do routine endoscopies for unrelated indications. So to classify each of them based on their endoscopic ultrasound appearance, their layer of origin, you have to decide about the treatment. The common subepithelial lesions are GIST or GI stromal tumors, lipomas, cysts, carcinoids, pancreatic rest, and rare ones are granular cell tumor and metastatic deposit. Not all of them require intervention. So appropriate diagnosis based on EUS features plus tissue-guided acquisition helps us guide how to manage these lesions. These are collections of some of our cases of pancreatic masses. So EUS is a cornerstone of evaluation and diagnosis of pancreatic masses. Cross-sectional imaging will give you an idea of presence or absence of masses, but detailed evaluation of mass in terms of its character, its location, its involvement, its extent, both vascular involvement and other things are in detail seen by EUS. So not all pancreatic masses required biopsy, but a detailed evaluation is must for any pancreatic masses by endoscopic ultrasound. So tissue biopsy should be done in EUS in pancreatic masses only when it impacts treatment. For example, if there is a metastatic disease with pancreatic mass, or in any ways it's a borderline resectable and you are planning a neoadjuvant therapy, or the tumor is in doubt whether it's inflammatory mass versus adeno-CA, or you are suspecting some alternative diagnosis like lymphoma, then you should definitely go for biopsies. Otherwise, in a straight away case of a pancreatic head mass without any significant vascular involvement and a patient fit for surgery, even a detailed EUS evaluation can guide you to directly go for surgery instead of doing biopsies. Similarly, when we deal with pancreatic cyst, US has become cornerstone in evaluation and deciding treatment interventions, where the main objective of EUS is to differentiate between pseudocyst and cystic neoplasms. Among cystic neoplasm, you have to differentiate between mucinous and non-mucinous cyst. Among mucinous cyst, you have to identify high-risk feature and then tailor down the management based on them. So only certain subgroup of cystic lesions require immediate surgery. Most of them can be managed expectantly or observation. So the first example is the serous cyst adenoma. The second example is the uniform anechoic. It could be a mucinous cyst or could be a pseudocyst. The fourth example is again a pseudocyst with some fluid. The last two examples are the presence of mucinous cyst with a mural nodule. So morphological identification, fluid acquisition for cytology and glucose, amylase and CEA and mutation studies, plus high risk feature in terms of lymph nodes and PD dilatation, PD communication. All this very important information we get from EUS. In our setup, mediastinal lymphadenopathy is a common scenario, and in other lymphadenopathies as well. So when they are adjacent to the GI tract, like periportal nodes, perigastric nodes, mediastinal nodes, EUS become a very simple and easy modality to get tissue, which gives you a good amount of tissue. So the above example is of sarcoid with a large mediastinal lymph node showing non-caseating granulomas. The second example is of conglomerated hypoechoic lymph nodes in periportal area, which is showing a Langerhans giant cell and caseating granulomas associated with tuberculosis. So another very important diagnostic indication is biliary pancreatitis. So MRCP is a good modality. It has a sensitivity of 90 to 95%, but EUS gives you a sensitivity up till 100% to diagnose a stone even less than 5 millimeter, which may be missed on MRCP. So we get a lot of clinical scenario where there is a dilated CBD and patient is having pancreatitis. We don't know whether there is stone or not, whether it requires ERCP or not. A number of studies have showed that a good diagnostic EUS can prevent unwanted ERCPs in this patient. Again, patients of recurrent idiopathic acute pancreatitis, where we don't know the exact etiology, we cannot prognosticate the patient, we cannot formulate a permanent line of follow-up and management. EUS becomes very important. There are certain features like presence of microcal, presence of sludge, presence of background chronic pancreatitis, presence of occult ampullary neoplasm, or a small pancreatic tumor or a divisum, which can be missed with MRCP and CT scan. So again, it has become compulsory to do an EUS in a case of unexplained recurrent idiopathic pancreatitis. So moving to the interventional aspects, there are few common interventions that I'll take you through. So EUS guided internal drainage of pancreatic pseudocyst and VON has become a very well-established procedure, as it has shown to reduce mortality and hospital stay and morbidity as compared to surgical intervention in patients complicated by VON or pseudocyst. So the basic principle we use is we try to find out exact amount of necrotic material, then decide on the stent that we use, whether it is a metal or a plastic stent. And the procedure is EUS guided access, fluid aspiration, wire is being coiled inside the cyst, dilatation of tract is being done, and then a metal stent is deployed. In this video, you can see at the end of the procedure, gush of pus is coming out into the GI tract. Nowadays, we have improved system by hot axios, where all these steps can be combined into one single instrument, and the whole procedure time can be reduced to as long as maximum 5 minutes. So once there are few cases where you drain off all the pus fluid and you still have patients being symptomatic, where you may want to go and do necrosectomy. So saving a patient from surgical necrosectomy has come a long way, and we can deal most of the necrosis, even up to the percent of 50%, effectively by repeated going through the metal stents. As you can see in the left example, a large amount of necrosum. In the right video, we are almost cleared of all the necrosis, and the healthy granulation tissues can be seen. EUS guided celiac plexus interventions is again a very important and a useful interventional procedure. Here in patients of metastatic intraabdominal malignancies, most commonly GB and pancreas, who are having refractory pain, the pain decreases their quality of life. So EUS gives a direct access to the celiac axis, and to identify celiac ganglion and intraganglion injection of ethanol can be done, which gives a good 70 to 80% chances of pain relief. We have extrapolated this data in the chronic pancreatitis as well, where instead of ethanol, we used bupivacaine and steroids, and the percentage of response may be less, but it's a useful modality in a certain subgroup of patients. And studies have shown it is far better than your CT-guided celiac plexus access, because the amount of area that has to be traversed by needle is very minimum, hardly 1 or 2 centimeter, and you are at the celiac axis, as compared to para-vertebral injection by CT-guided. Now, ERCP gives us a success rate of 90% at best of the centers. 10% cases require additional modalities, which includes using various kind of advanced ERCP techniques like pre-cut or double guide wire, or redoing a procedure. But nowadays, US guided biliary access has given us a lot of increase the success rate of biliary drainage interventions. So if you fail ERCP in the same setting, we can convert it to US guided drainage procedure. Lots of modalities are the various techniques have been described. This one is an example of US guided choledochoduodenostomy. To simplify, we access the bile duct through the duodenum, at first part of duodenum. A dilated bile duct is accessed using under US guidance by using the 19-gauge needle, and the tract is dilated, and a fully covered metal stent is placed to create an anastomosis between bile duct and first part of duodenum instead of going through the traditional route. Another very important intervention which is being increasingly used in day-to-day practice is US guided variceal coiling for gastric varices. So gastric varices has been always troublesome for all gastroenterologists for quite a long period of time. They are the notorious varix as compared to the esophageal varix. They bleed late, but once they bleed, it's very difficult to control. So the amount of glue injection varies if you do endoscopically. So EUS gives us a clear control over the amount of glue that needs to be injected. There are available metal alloy coils, which has a length of around 2 to 15 millimeter and loops for 2 to 20 millimeter in diameter. So based on the size of the varix, we select the coil, we puncture the varix through the EUS guided needle. We inject the coil, and once the coil is injected, we reduce the amount of glue that is required to obliterate the varix. Studies have clearly shown that combination of glue plus coil is better than glue in terms of reducing chances of glue embolization and more effective variceal obliteration. So US guided GI anastomosis, this is the most exciting in the advanced part of US interventions. So the chief indications are US guided gastrojejunostomies, US directed transgastric ERCPs for post-Roux-en-Y bypass patients, and US guided drainage of afferent loo obstruction. Just to explain you simply, in patients having proximal duodenal or pyloric obstruction, either due to pancreatitis malignancy or gallbladder malignancy, who are unfit for surgery, US guided drainage provides a very good modality to have internal anastomosis being there. So in this, we bypass the obstruction using various kinds of techniques are described. One is freehand, other is by e-pass balloon guided. So the main aim is to bypass the obstruction into the jejunum and to distend the free part of jejunum with large amount of saline and methylene, so that distended jejunal ball approximates with your surface of your stomach, which you can then identify US guided, and you can place an hot axial stent. It's a complicated procedure, but if you are able to do it, then patients are having much improved quality of life as compared to surgical. As it is associated, studies have shown it, it is associated with better clinical success, less adverse event, and re-intervention, especially when compared to our traditional duodenal stenting. So last couple of slides. So various types of US specific stents are available, which has made these kind of interventions possible. So dumbbell stents are used when we need to create a fistula tract to create anastomosis or to drain certain collections. So they are Axios, Paxos, Nagi, which has different kind of anastomotic strength and different kind of flares and different kind of length. Then there are tubular types which are useful for the biliary drainages procedures like Geobor stent, Hanaro stent, and Bona stent, which have different proportion of covered and uncovered part and different types of flares to reduce migration. So a lot of instruments are being innovated, and this is an exciting area of research and innovation in interventional endoscopy. So these were the traditional uses that has been in use for last 5 to 10 years. Now I'll talk about some evolving role, last couple of slides. So endohepatology, as I told in the beginning, US guided portal pressure measurements, US guided shear wave elastography measurement, US guided liver biopsy, and US guided tips. So one-stop solution. Yeah. So US can offer one-stop solution for chronic liver disease patient if these interventions are in clinical practice. They are still at clinical trial stage. Similarly, for oncology practice, US guided radiofrequency ablations, US guided ethanol ablations for functioning and non-functioning pancreatic neuroendocrine tumor, large pancreatic cyst, especially for patients who are old and who are frail, who are unable to undergo extensive pancreatic surgeries, and US guided injection therapies to deliver chemotherapeutic agent intralesional. So all these are exciting prospect to make minimal invasive approach for this kind of complex disorder feasible, as US can help us reach various kind of this kind of pathologies with ease through the GI tract. Thank you.
Thank you, Nikhil, for a nice presentation. Can you stop the slide sharing?
Yeah.
Got it. So can you hear me?
Yes, sir.
All right. So thank you. Nikhil, if I have to ask you a couple of questions. One is that which are the areas where you think there is no alternative to EUS at this moment? It's a very evolving technology and is gradually replacing conventional radiological and ERCP or endoscopic approach. But which are 2 or 3 places where you think there's no alternative now?
So, given the large randomized trial of surgical approaches in pancreatic fluid collections and improved result and improved patient outcomes in endoscopic therapies, I think US has become first line of approach for drainage of peripancreatic fluids which require drainage and who are indicated. So that is one area where US has replaced surgical approaches wherever feasible. Second,
yes.
Yeah, second will be US guided tissue acquisitions. So though radiological tissue acquisition can be done in various, in almost any part of the body, but since it's because of its close approximations, most of the time we have to traverse a very small distance to get US guided tissues. So chances of spread of tumor and surrounding in vessel injury, since we have a real-time view of blood vessels and everything, US guided tissue acquisition, especially in pancreatic and peripancreatic masses, I think US has become #1 modality.
I think one other area which you possibly missed out is celiac axis block. I think I remember the time about 15 years or 20 years back when you used to ask the radiologist to do the celiac axis block, and they would either do a CT guided or mostly CT guided or US guided, and sometimes just on the fluoroscopy. But I think in the last 10 to 15 years, the scenario has completely changed. And now nobody, possibly those who have in the US, would be doing a celiac block by any other technique rather than by EUS.
Definitely.
There's a question as to what should be the preferred modality of sampling for perihilar and peripancreatic lymph node. I think peripancreatic lymph node, there's no controversy. EUS guided is usually the technique. One of the other reasons why it is not only the short route, but also that you are not contaminating the area which would not be included in the surgery if the patient turns out to be a resectable tumor.
Concept of seedling of tumor has definitely been, it is over exaggerated, no doubt, but it is there, and US minimizes that risk. So considering that, US is the first line approach. In perihilar node, the same concept applies, because percutaneous route, you have to traverse the longer area, and the chances of needles track metastasis is more for a CT guided approach than this US guided approach. So if there is no obvious metastatic disease, and if you are contemplating surgery, and if US is feasible, always US guided should be first.
So there was a question related to the first topic, if Avnish is still around, on the chat box, as to when will you go for surgery in patient with obscure GI bleed? Avnish, you have any answer if Avnish is still around?
Only indication I think would be, sir, hemodynamic instability. If the patient is hemodynamic unstable, then I'll consider surgery. Otherwise, most of the times we are able to find the cause of the bleed. Because the only problem with Not finding the source of bleed is the intermittent nature of the bleed. Otherwise,
Or-
most times we find the bleed.
All right. So we will now move on to the last presentation of the day by Dr. Akash Roy. And Dr. Akash Roy is DM in hepatology from PGI Chandigarh. And he has worked also in SGPGI Lucknow and has been at Apollo Multispecialty Hospital as the hepatologist for the last 1 year. He has won several awards, including awards in Singapore Hepatology meeting, as well as a research award in AASLD meeting. He's a bright young hepatologist, and let's listen to him about his approach to HCC as of today. Dr. Akash Roy, please.
Thank you, sir, and thank you the team from Gapio for this opportunity. Over the next 15 minutes, we'll take a walk through how do we approach a stage-based management. As I understand the diverse audience, we'll try to keep it simple and understand what the basic philosophies of staging in hepatocellular carcinoma is, as well as how does it apply to its management. So let's start off with a case. We have got a 50-year-old diabetic with no viruses. He's a practicing lawyer. He's detected to have a liver sol in USG. You go ahead, do a CT, and you find a classical HCC, which has involved the portal vein. I want to focus on the term classical HCC because in the next slide, we'll be coming on to it. The patient is child A of MELD of 10, alpha-fetoprotein of 100. He's got small varices on endoscopy, and he has never bled. So the question comes that what would you offer him? And as we walk through the next few slides, we'll try to answer this. So what is a classical HCC? A classical HCC is diagnosed on a CT or an MRI with very classical symptoms, of which the two most important are an arterial phase enhancing lesion, which has to be non-rim. That means this is a lesion which enhances in the arterial phase, and it's not only in the corners of it. The entire lesion is enhancing, which is called a non-rim enhancement. And the second important thing is the size of the lesion. And then you look out for additional features like a washout and an enhancer capsule. So let's see this slide. This is a lesion which is around 18 mm. And then you've got an arterial phase enhancement. This is what a classical washout should be. And it has also got an enhancing capsule. So this points to you to somewhere of a lesion which is around LR4 or LR5, according to the LIRAD's classification system for HCC, which we call as a definitive HCC. So this is what a definitive HCC looks like. And now this can be of various sizes. There can be multiple tumors. There can be single tumors. There can be tumors more than 5 centimeters. There can be tumors less than 5 centimeters. So this is why we need a staging system in hepatocellular carcinoma. If you've got somebody with a lung cancer, you only have the cancer in the lung. Many times the background lung is normal. But the story is not the same with liver cancer. You've got on one hand, the tumor which is giving you a problem, and other hand, you've got the liver disease which is giving you a problem. So you want to chase the one, the other might start going away from you. So any staging system has to incorporate both the tumor-related factors as well as the liver-related factors. And again, we'll see patient-related factors. How do we approach? Because we stage this to choose. Our primary therapy would be dependent upon this. And again, what those additional therapies is. Because HCC, as any other cancers are there are multiple rounds of therapies that might be needed. So this is how any staging system of HCC is divided upon. So you need to assess the tumor burden. What is the exact size of the particular tumor? How many tumors are there? Whether it's one part of the liver or it involves both the lobes of the liver. Whether the portal vein has been involved, whether the hepatic veins have been involved, or there is distant metastasis beyond the hepatic portal vein circulation. Then you go on to assess the liver function. What's the child status? What is the MELD score? What is the albumin-bilirubin score, which is basically a subtraction between the albumin and the bilirubin levels? And does the patient have portal hypertension? And a combination of both these affect your overall health status, which is again divided by your tumor burden as well as the liver function, which we classically define by the ECOG score, symptoms, and quality of life. So because of these three reasons, over the years, there have been multiple systems that have come up in the management of HCC. If you see these systems that all incorporate various sizes and various tumor sizes and hepatic functions that are there, and some of them also tend to include the alpha-fetoprotein levels, which is a marker for HCC. But the most important and most commonly used staging system that has been there is the Barcelona Clinic for Liver Cancer staging system, which has been used predominantly for staging and classification management of patients with HCC. So this is what the traditional BCLC algorithm looks like. So before we go on to it, there is something which needs to be understood in details. And what is an ECOG performance scale? That is, if you've got somebody who's scale 0, means he's asymptomatic, and somebody who's scale 4, who's bedbound. And second, what is somebody with a preserved liver function? For all practical purposes, we define preserved liver function as a person who is child A without any ascites. There are some school of thought which say that you might be taking patients with child B who's less than 8, but this is still not universally accepted. So once we know these two status, let's see how any liver tumor would be divided according to the BCLC staging system. So you've got a single tumor, your liver function is preserved, and you have got perfect performance status. You fall into stage 0. If you've got a single, which is less than 3 centimeters, 2 to 3 nodules, again, your PS is 0, and you've got a preserved liver function, that's stage A. You go on to intermediate, where you've got multiple lesions, or which is unresectable. That means you're not candidate for surgery anymore. Once you invade the portal vein, you fall immediately into the advanced stage HCC. And once you have reaches a poor performance status, irrespective of whatever the cause is, whatever your tumor size is, if you have got a poor performance status, or you have got anybody who has got end-stage liver disease, you automatically go into the terminal stage. So this is what the basic philosophy of any of the BCLC classification system is, and we'll slowly go on to adjust and adapt to these staging systems as to because each and every management strategy would be dependent upon this. So this BCLC staging system that was described in the previous slide was an older version. There's a school of thought which says that this was too compartmentalized. So this is the updated version of the BCLC staging system, which is the BCLC 2022. If you see, the philosophy still remains the same. You still have early stage, very early stage, intermediate, advanced, and terminal. But here, some other things have come in. That is, you have an individualized approach. In the original BCLC, you did compartmentalize the things that if you fall into A, you do this. If you fall into B, you do this. If you fall into C, you do this. Now, the idea is you can migrate between these stages depending upon the patient's individual priorities and what the individual statements and condition of the patient is. That gives in the concept of treatment stage migration, which is the new thing that's there in the BCLC 2022 system. So let's see what are those stage-based management options. Number one, resection. Where does resection lie today in the management of an HCC? If you see this very carefully, there are only 2 areas where resection can be tried. That's very early stage and early stage, when you have a normal, that you do not have clinically significant portal hypertension, that somebody without varices for clinically, or even better if you have got a HVPG. So somebody who doesn't have clinically significant portal hypertension, has a very small tumor, they are the only candidates for resection. But this comes with a caveat, specifically from Japanese studies, because they have a lot of non-cirrhotic HCCs, which actually doesn't apply to these classification system, that if you have got a good liver volume, and if you've got a very peripheral tumor, then you might just get away with that tumor, even if it's more than this. So these are basically the 2 or 3 indications in which we can do a resection. So which are those groups that you will actually be offering resection? If you see the plot out here, you want to go to somebody with a low risk of liver decompensation, which is less than 5%. So if you tick all these check boxes, you come to somewhere in this checkbox, which is that you have a hepatectomy, which is minor, that is less than 3 segments, your MEL score of less than 9, and no portal hypertension. This is the only group that you're going to offer a resection as a treatment modality for hepatocellular carcinoma. Liver transplant, the second option. So the initial stories with liver transplant were very dismal, with very high chances of recurrence rate. Then people gradually began to understand that if you take 2 larger tumors or tumors which are outside the liver surface architecture into the portal vein, you tend to do bad. So then they developed what is called the Milan criteria, which is simply single lesion less than 5 centimeters or 2 to 3 lesions, none of which is more than 3 centimeters. This gives you a 4-year recurrence-free survival rate of 83%, which is what we are going to target at. So this is the classical criteria. Any patient with HCC who falls into this criteria should be upfront considered for transplant. But we are greedy people. We want to do more and more larger tumors for transplant. So there are multiple criteria that have come up, which are larger than the Milan criteria, like the UCSF criteria, where you go up to 6.5 centimeters, or the 3 tumors, which is largest less than 4.5 centimeters. So you can go up, But as you go up more and more, you try to expand and do larger tumors or multiple tumors, you suffer from HCC in something called a metro ticket concept, that you can keep on increasing that tumor size, but that would come as a cost to you of high rates of cirrhosis. So what we have settled today in most of the transplant center, the classical criteria is Milan. Maybe in some transplant center, they would go up to UCSF, but not beyond that. Local and regional therapies, which form the second and perhaps one of the commonest used modalities nowadays in HCC management. So they are of three types: ablative therapies, which can be chemical or energy-based, which can be again microwave, radio frequency, cryo, irreversible electroporation, or even ultrasound-based therapies nowadays, transcatheter therapies, or radiation-based therapies. So what is the basic idea that we are going to do these therapies for? Number one, these ablative therapies like microwave and RFA, they burn your tumor out. And since these are targeting very small areas, they can actually cure you of that particular tumor. With the transcatheter therapies, these actually don't kill your tumors completely. They are used for two purposes. One, if you're going to say somebody's tumor, which has got a single lesion, which is 6 centimeters, that means he's out of Milan criteria, which is only up till 5 centimeters. So you do a radiation-based therapy or transcatheter therapy, bring that size down to less than 5 centimeters, which is called as downstaging. Or you have got somebody who has a tumor, which is say 5 centimeters, that's within Milan, but he has time to transplant. You don't know when he's going to be transplanted. And you cannot allow that tumor to stay like that, because one day or the other, it's going to come out of your liver. So there you do this to what is called bridging to transplant, that a tumor which is susceptible to be transplanted, you're waiting for the time, you bridge it and lower its size so that it stays in control. And these therapies have been shown to improve overall survival. So these are the various techniques that have been used. The most two commonly used modalities over many centers are radio frequency and microwave. These are very good modalities in 3 centimeters, even going up to 5 centimeters tumors. This can be combined with TACE for 3 to 5 centimeters. Only problems are subcapsular or subdiaphragmatic lesions and vessel proximity, because you tend to lose the heat. Microwave has been found to be similar in comparison to radio frequency ablation. Head-to-head trials also show similar performance. Cryoablation and irreversible electroporation is available in very few select centers. TACE is another modality which is very frequently used in many centers. So what are those patients that you're going to take up for TACE? You take patients which has about 3 to 5 or more than 5 centimeters of tumor, which are multifocal, which have got a tumor burden of less than 50% of your liver size. Your liver functions has to be preserved, and also the renal functions has to be preserved. So you exclude patients who are advanced B, who have got biliary obstruction, complete portal vein thrombosis. This is important because if somebody has got a partial thrombosis, you may still be offering it. And large tumors which are more than 10 centimeters. So this is where the ablation and TACE modalities stand today in the management of HCC. This is the small tumors up to 2 to 3 centimeters. You're going to be offering ablation therapies. Once you get to this intermediate stage, larger tumors go up to TACE. But also remember that there is one segment when you've got a single lesion of around 5, 6, 7 centimeters, TACE or radioembolization, which is again available in very small centers, can also be taken up. Systemic therapy, which is the new dawn of therapy for hepatocellular carcinoma. We only had sorafenib till about 2014-15, and of late, over the last 3 years, we have got a spate of molecules that have come over, and which have got defined as one of the frontline therapies in patients who go into this advanced stage. So the poster boy of today's systemic therapy over the last 2 years have been the immune checkpoint inhibitions. How to understand it: whenever you got a cancer cell, it interacts with an immune cells by these receptors on the cancer cells and the immune cell receptors. These interact with each other, and when they interact, these immune cells are inactivated. So you've got PD-1, PD-L1, and CTLA-4. So what happens when you block any one of this? Either you block the PD-L1 or you block something like a CTLA-4, you're going to decoil or decouple these two and start making these drugs act. So the IMBRAVE trial, which was a landmark trial of 2 molecules, that atezolizumab and bevacizumab. Before that, our overall survivals used to be about medium overall survivals used to be around 6-7 months to about 9 months. And this is the first trial which showed that by the time of treatment completion, not even 50% of the patients had died, giving its overall survival against sorafenib. So that has become the front line for any patients with advanced HCC. But to make it very simple, whom do you give? You give it to advanced HCCs. You give it only to people with child A, ECOG performance status 0, 1. Patients who have AFPs more than 100 or CRP more than 1 have been shown to be predictors. Check for varices because one of these molecule is a VEGF inhibitor, which can cause you to bleed. Check for proteinuria. Check for thrombocytopenia, and don't use these in patients with cardiovascular risks, bleeding diathesis, or arrhythmias. Sorafenib and lenvatinib, which are the 2 molecules which are again going to be used if somebody is not affordable for immune checkpoint inhibitions. Lenvatinib has become the standard go-to drug nowadays. It has been shown to be non-inferior in overall survival with sorafenib. The only problem with lenvatinib is that in child B and C, we still don't have real-world data, but that is going to come up. So as of current day practice, in somebody who's got an advanced HCC, only suitable for systemic therapy, lenvatinib is going to be the go of choice. And this is the emergence of combination therapies in HCC nowadays, that is addition of lenvatinib with TACE or other modalities. So we come back to our case. So you have got that case which we had discussed in the beginning. So what will we be offering to this patient? So this patient has got an advanced HCC with a portal vein involvement. So he goes into B and C categories of BCLC. So what we will be offering them, the options that would be there would be to combine or use singly any of the local regional therapies or go ahead with frontline systemic therapies, which comes with its own expenses. So in a nutshell, to summarize stage-based management of HCC, look at the tumor burden, numbers and size and what it is involving. Look at the liver function, look at portal vein involvement, look at whether there is distant metastasis, see the performance status as a whole, and look at the availability of that setting in your current area, look at the cost, and always focus on the patient preferences. No CSPH, resection, small tumors, ablation, transplant eligible, transplant, larger tumors, transcatheter therapies, out of liver, systemic therapy, TARE, TACE, or combo. And if this doesn't fall into any one of this, it can be just at best supportive care. Thank you.
Thank you, Akash. A very comprehensive overview. All the 3 presentations were, I think, very, very good, high quality. We are running short of time, but maybe 1 or 2 questions. One question which is asked by Nikhil to you is that is portal vein thrombosis a complete contraindication to liver transplant?
So portal vein thrombosis first has to be looked at whether it's a malignant portal vein thrombosis or a non-malignant portal vein thrombosis. As of today, a malignant portal vein thrombosis, according to guidelines, is a complete contraindication to transplant. But there has been trials specifically by the Medanta group in India, where they tackle the portal vein thrombosis with modalities like SBRT, make it amenable that this means the portal vein thrombus, which is malignant, has been completely destroyed, and then take the liver for transplant. So that's the approach that has been utilized in many cases now.
So do we have long-term follow-up on this subgroup of individuals?
So they have come up with the paper with I think last year. They've shown the long-term follow-up. Follow-up is excellent. The overall 5-year survival is at par with the others that are there, means other modalities that are there. But they're mostly sticking to BP1, BP2 portal vein thrombosis.
One question, when you are talking of out of liver disease and you still talk about TACE and TARE, what are we trying to achieve when the disease is spread outside the liver?
Yes. So the disease, the option for TACE and TARE in such cases would primarily be coming from how we can tackle that tumor which is already spread out. We need to tackle it from 2 aspects. The liver tumor itself has also to be tackled, and also if you've got a portal vein involvement, that can also be tackled with modalities like SBRT. Now what they are moving into much more, which is again very interesting, is that people have started using a combination of immune checkpoint inhibitors or even systemic therapy like lenvatinib, and use them for a systemic therapy, and also keep on doing a local regional therapy for the liver tumor.
All right, Akash, wonderful. I think I'll move on to Dr. Sushil Jain for the final comments. Once again, thank all the 3 speakers and of course the GAPIO for organizing this. Dr. Jain.
Thank you, sir. Thank you for organizing this session, and it was a short duration, but you managed to procure all the 3 excellent speakers. It was a pleasure joining the session. And I would also like to thank the backend team of GAPIO, Mr. Jitendra, and the IT team for organizing and helping out us in this session. We look forward for more such sessions during the coming weeks. Thank you.
Thank you. Thank you. Thank you, everybody. Good night.